In this video, we are going to discuss about class 4 and class 5 antiarrhythmic drugs. So class 4 antiarrhythmic drugs, as we all know, these are calcium channel blockers. Now, the predominant type of calcium channels in cardiovascular system, they are L type of calcium channels. So these drugs produce antiarrhythmic action by blocking these L type of calcium channels in the heart. Now, calcium channel blockers, it's a very broad class of drugs, and all the calcium channel blockers do not produce antiarrhythmic action. In order to understand that, we need to understand the classification of calcium channel blockers. So, calcium channel blockers can be divided into two basic groups. These are non-dihydropyridines, and the another class is dihydropyridines. So, dihydropyridines includes all the drugs ending in dipene. So, all the dipines are included in dihydropyridines. These include drugs such as amlodipine, nifedipine, and clevidipine. So these drugs are dihydropyridines. Now the next class of drugs, that is non-dihydropyridines, includes drugs such as Verapamil and Diltiazem. So there are two basic classes of calcium channel blockers: non-dihydropyridines and dihydropyridines. Dihydropyridines include amlodipine, nifedipine, clevidipine. Now these calcium channel blockers will be discussed in detail in the topic of vasodilators. However, here we'll just briefly look at them and have some idea how they can produce antiarrhythmic action. Non-dihydropyridines, they can block calcium channels in blood vessels as well as in the heart. So because of blocking calcium channels in heart, they can produce antiarrhythmic action. Whereas dihydropyridines, they can block calcium channels only in blood vessels. Now, and the effect on blood vessels is more potent in case of dihydropyridines. Now, non-dihydropyridines, because of their effect on blood vessels, they cause vasodilation, and as a result of vasodilation, that there is reflex tachycardia, and as a result of reflex tachycardia, there is mild increase in heart rate. Now, because of their the effect of non-dihydropyridines on the heart, that is on SA node and AV node, because of the block of calcium channels in SA node and AV node, there is decrease in heart rate as well as decreased conduction through AV node. So one effect produces increase in heart rate and other effect produces decrease in heart rate. So the net effect of non-dihydropyridines is nearly normal heart rate. So they do not affect heart rate. However, they produce AV nodal block, and they can also cause vasodilation. And because of their effect on AV node, depressant action on AV node, these are used in various arrhythmias. So dihydropyridines, they block calcium channels in blood vessels and cause vasodilation, and this effect is more potent as compared to non-dihydropyridines. Now dihydropyridines, they cause vasodilation, which is more potent, and this results in reflex tachycardia, which causes increase in heart rate. Since this effect is more potent, so the increase in heart rate in this case is more as compared to non-dihydropyridines. Now, so the net effect of dihydropyridines is vasodilation and increase in heart rate, and the effect on AV node is absolutely zero. So the block of conduction through AV node can be produced only by non-dihydropyridine, so they are used in case of arrhythmias, and the main drug used is Verapamil. Other drugs, that is dihydropyridines, they cannot be used in arrhythmias. In fact, they can cause various types of arrhythmias because they cause increase in the heart rate. Drugs such as Verapamil and Diltiazem, they are effective in arrhythmias because of their depressant action on AV node. So they can be used in those arrhythmias in which the problem is in the atria, and by causing AV nodal block, they can prevent the transmission of arrhythmia to ventricles. So such arrhythmias are supraventricular tachycardia and paroxysmal supraventricular tachycardia, and the arrhythmic effect is due to AV nodal block. Now these drugs, they can also be used in patients of stable angina. In patients of stable angina, the main problem is vasoconstriction of coronary artery, so they can cause dilatation of the coronary artery without causing significant increase in heart rate. In other words, myocardial oxygen demand is not increased in these patients, so they are effective even as monotherapy because of vasodilation and because they do not increase myocardial oxygen demand. However, the other class of drugs, that is dihydropyridines, if they are used in patients of stable angina, they can produce vasodilation. However, because they increase heart rate, they also increase the myocardial oxygen demand. So they will result in worsening of angina, and they cannot be used as monotherapy. They have to be used along with beta blockers. Now, non-dihydropyridines, they are used for treatment of supraventricular tachycardia and paroxysmal supraventricular tachycardia or similar arrhythmias. However, if they are not available, we can also use beta blockers instead of them. But both these drugs should not be given together due to risk of causing severe myocardial depression. Now let us move to the last class of antiarrhythmic drugs. That's class 5 antiarrhythmic drugs. These drugs are named as miscellaneous drugs. So this class contains all other drugs which do not fit in other four classes. So the first important drug in this class is known as digoxin. So digoxin will be studied in detail in congestive heart failure. In However, this digoxin, it also produces antiarrhythmic action because of its depressant action on AV node. So it can be used in arrhythmias which are mainly associated with atria, such as supraventricular tachycardia and paroxysmal supraventricular tachycardia. So these arrhythmias, this drug can prevent the transmission of this arrhythmia to ventricles by causing AV nodal block. Now, the next drug in this class is known as atropine. As we all know, atropine is a parasympathomimetic drug. So this atropine, it can produce parasympatholytic effect. Sorry, it's a parasympatholytic drug, and so it blocks muscarinic receptors, and as a result, there is increase in activity of the heart. So this drug is the drug of choice for treatment of bradycardia, so or other brady arrhythmias. We give atropine. Atropine is also used for the treatment of arrhythmia which is due to inferior valve MI, because whenever there is normally for MI, the MI induced arrhythmias, we use lidocaine because of its better action on ischemic tissue. However, in case of inferior valve MI, there is irritation of vagus nerve which produces parasympathomimetic effect. So in order to counter this effect, we use atropine which produces parasympatholytic effect. Now the next important drug in this class is adenosine. So adenosine, as the name says, it's a nucleoside by nature. So adenosine is the drug of choice for the treatment of acute attack of certain arrhythmias, such as for the acute attack of supraventricular tachycardia and paroxysmal supraventricular tachycardia. Now it's used for acute attacks because it is very fast acting drug. Adenosine is also a very short acting drug. Its half life is only few seconds, almost 1 to 5 seconds, and since it's a nucleoside, it cannot be given by oral route, it has to be given by IV route. And whenever it's given by IV route, the cells of our body, they take up adenosine quite fast because of presence of certain proteins called as adenosine uptake proteins. So whenever we give adenosine IV, these cells, they take up proteins quickly, and this decreases the levels of adenosine in the blood. As a result, its half life is very less. Now, adenosine is also a very fast acting drug because of which it's used in acute attacks. Now, whenever we give adenosine through intravenous route, the question is, can we give it through the median cubital vein? And the answer is no, because whenever we give it by median cubital vein, the time it takes to reach the heart, that is going to be a few seconds, and in that time this adenosine is going to get metabolized as its half life is very low, so it will not produce the required effect on the heart. So adenosine, it's given by rapid IV infusion through the jugular vein, because jugular vein is very close to the heart, and so adenosine is going to take less time to reach to the heart and produce its effect. This route of administration is sometimes called as rapid IV push. So adenosine, it cannot be given by slow infusion, and it cannot be given through median cubital vein because of its rapid metabolism. It has to be given by rapid IV push. Now let us try to understand the mechanism of action of adenosine. So adenosine, it is going to stimulate adenosine receptors. Now there are various types of adenosine receptors, such as adenosine 1 receptors and adenosine 2 receptors. Adenosine 1 receptors, they are present predominantly in the AV node and in the bronchi, in the bronchial smooth muscle, and adenosine 2 receptors, they are present in blood vessels. Now adenosine 1 receptors, they are inhibitory type of G protein coupled receptors, so they will have a depressant action on AV node, and in the bronchi they are going to cause bronchoconstriction. And adenosine 2 receptors, they are stimulatory type of G protein coupled receptors, so GS type of receptors, they produce relaxation of smooth muscle, so in the blood vessel they are going to cause vasodilation. Now, because of bronchoconstriction, adenosine is contraindicated in patients of bronchial asthma and COPD. It's also contraindicated in patients who have undergone heart transplantation, because in transplanted heart, the nervous innervation cannot be restored. So because of no nervous innervation, there is a phenomenon called as denervation hypersensitivity. That means there will be upregulation of receptors in the heart because of denervation, and because of this upregulation, the heart is going to become more sensitive to chemicals such as adenosine. So if adenosine is given, it's going to cause excessive effect because of upregulation of receptors, resulting in myocardial depression. So it is contraindicated in these conditions: bronchial asthma, COPD, and transplanted heart. Now, if in case of bronchial asthma or COPD, there is an acute attack of supraventricular tachycardia or PSVT, then normally we use adenosine, but here we cannot use adenosine. So then we shift to beta blockers, but again in this case we cannot use beta blockers because they'll produce bronchoconstriction. So in this case the drug of choice is Verapamil, which is a calcium channel blocker and produces depressant action on AV node. So it's a drug of choice in case of these arrhythmias in bronchial asthma and COPD. Now let us discuss the side effects of adenosine. Because of vasodilation, adenosine can produce hypotension, and because of bronchoconstriction, it produces dyspnea. These are the common side effects caused by adenosine. Now there is another side effect of adenosine. Adenosine can never be used in atrial fibrillation or flutter. In fact, it can itself cause atrial fibrillation and flutter. So if this is the plateau potential of atria, adenosine also produces an additional effect. It opens potassium channels. So because of opening of potassium channels, it is going to cause early repolarization. As a result, the QT interval will be decreased, so there will be more cycles in per minute. So it's going to increase the rate of atria that can result in atrial fibrillation or flutter. So this is a paradoxical side effect that adenosine produces. It normally treats atrial arrhythmias, but it cannot be used to treat atrial fibrillation and atrial flutter because it itself has risk of causing these arrhythmias. Now let us take a look at interactions of adenosine. So there are two main interactions of adenosine. So the first interaction is with theophylline. So theophylline is a drug. It's used in bronchial asthma and it's an adenosine receptor antagonist. It causes bronchodilation. So once theophylline is used, then we cannot give adenosine to the patient because of this adenosine receptor antagonism. It's going to result in ineffectiveness of adenosine. Another important interaction is with drug called as dipyridamole. Now dipyridamole, it inhibits adenosine uptake proteins in cells. As a result, these cells cannot take up adenosine from blood. So this is going to result in increased levels of adenosine in blood, and it can result in toxicity of adenosine. Now the last drug in this class is known as magnesium sulfate. Magnesium ions, they close calcium channels. So because of closure of calcium channels, they are going to produce their effect on the plateau potential. So they are going to decrease the duration of plateau in the action potential graph. Now let's take a look at the action potential of plateau potential. So the plateau is due to the potassium efflux and calcium influx occurring at the same time. So these two charges balance each other, and as a result there is a plateau is formed. So whenever calcium channels close, then it's followed by rapid repolarization, and this completes the action potential. So because of blockade of calcium channels, there is the repolarization occurs a bit early, so QT interval is shortened, and hence this drug, this MgSO4 can be used in patients of long QT syndrome. Now again, in patients of long QT syndrome, there are two aspects of management. For the treatment of an acute attack of long QT syndrome, which presents as a Torsades-de-Pointes arrhythmia, the drug of choice is MgSO4. And for the long-term management in these patients, now the main aim of long-term management is to prevent the precipitation of an acute attack. And acute attack, that Torsades, occurs whenever there is a surge in the release of catecholamines in the body. So these catecholamines act through beta receptors. So for long-term management, the drug of choice given to these patients are the beta blockers.